The government, academic institutions, everybody was scared about what would happen if psychedelics were unleashed on society. Psychedelics were locked away, Schedule I drug, no beneficial human use at all until 1999. And Dr. Roland Griffiths resurfaced the use of psychedelics for psychiatric care.
But then I moved over to my therapy work, and that's been some of the psychedelic work. Now, within the therapy model, there is psychedelic assisted therapy that is legal in Colorado for mental health therapy.
And so I will say, my mentor, Dr. Benjamin, who was the quintessential pediatrician, everybody loved Dr. Benjamin.
Okay.
And he would say, you're not a parent until you have 2 kids. What do you mean? But I wasn't a parent, so I didn't know what he meant. And what he meant was you're not a parent until you have to manage resources.
I mean, I have clients that have been through so many different therapeutic models for depression, anxiety for years. And after 6, 7 sessions, they're out. Depression is better. Anxiety is better. So that's been extremely incredible.
Welcome to the Dr. Thornburg Wellness Podcast, where pediatrics meets functional medicine, blending science-backed insight, common sense, and a touch of shamanic wisdom from a father of 8. Hi, I'm Dr. Brian Thornburg, and today on You Asked, I am sitting with Katie Tyrrell-Wyman. She is a licensed social worker, therapist, end-of-life doula, and psychedelic integrative therapist. She is visiting Naples. She's also my second cousin, maybe once removed, but her dad and my dad were first cousins. So we went to dinner last night and we started talking about life and having kids and looking at kind of the whole trajectory of life. And her dad's with her, my dad's first cousin, and he is in early stages of Alzheimer's. And then, she's a mom of 3 kids. And we were just talking about what it's like to go through the different stages with parents getting older and what it's like to be a parent and what she does for a living. And I thought there would be a lot of positive information that we could share, just having a conversation about all the good things and the bad things that life hands us and how you deal with it. Well, welcome, Katie.
Thanks for having me. This is so fun.
Yeah, this is great.
And hard and fun and everything life brings, right?
Right. So I think this is the first time we remember meeting, but
Yeah.
I was interviewing for medical school in Chicago, and you were in high school still, and I stayed in your back room.
Yeah.
And I think you ran through the kitchen at one point, or I
Right.
heard you in the morning getting ready to go to school.
All 4 of us were
Yeah.
running around somewhere, and you were trying to do something official, right?
So this is great. So we went to dinner last night, and your dad's very special to me. He was with me sitting outside of the operating room when I had my tonsils taken out when I was 3 years old, because I think he was interning. I don't think he was in medical school yet. I think he was still at Notre Dame.
Okay.
And your dad or your grandfather performed the surgery to remove my tonsils.
Oh,
and
I didn't realize that.
So I have very long and fond memories of your dad, and of course he was a doctor too, but internal medicine. So he does the other part of what I do.
Yeah.
I get the good part, and he gets the adult part. So,
the aging, and he had the end part, and now he's at his end part too.
Right. So, so tell me what it is you do, how you got into this field, and
I mean, I guess I got into this field kind of through my dad in a way. Life hands you the hard stuff. I maybe took the suffering and made it into something I could give back to other people.
Explain that more. Why you're talking about suffering? Because I know some of the background. But.
I witnessed. I think I first witnessed my grandma from my mom's side die. All of our family gathered around her, and I saw my dad was also her doctor, and he really took the approach that you don't have to throw every single intervention to keep someone going. And my grandma didn't want to keep going, meaning yes, we have all of these interventions here in our medical system. However, she wanted to be comfortable. And there was this amazing thing called hospice. And I saw the beauty of hospice. But hospice doesn't bring everything. Yes, there's medication and there's comfort measures, but our family kind of brought this spiritual element, this people element, and I saw the beauty in that. And I started thinking, I want to do that. And my grandfather, then on my dad's side, he was a doctor. My grandmother, Sally, on my dad's side, she was an OBGYN. And I never had like the science mind, but I always knew I had like this other spiritual side of myself. And I thought, well, how do I pair this piece of curiosity and spirit with this other medical world? And I thought, well, gosh, death isn't a medical event, actually. It's actually just a transitional event. And so I started exploring different fields, and then I started investigating this concept of palliative care. And palliative care was, well, it was a place where there was a team. And then I realized, well, you could be a social worker and a therapist. And then I started exploring, well, it didn't have everything. And then I started exploring end-of-life doula. And I kind of thought, well, I'm just going to create my own thing. I'm going to create my own career.
So you trailblazed kind of the
Yes,
path you're on.
exactly.
Yeah.
And it didn't exist. Like, it wasn't like, oh, okay, I'm going to be a licensed, clinical social worker, and I'm going to do this thing because it's already out there. I said, okay, I'm going to train as an end-of-life doula, and I'm going to get my licensed social work degree so that I can be official. And I'm going to train at Rush in palliative care. And then I'm going to put it all together. And then now I'm out in Colorado and I'm working in grief. I've been doing hospice. And then I've kind of been dabbling in this other piece. And I work in an incredible practice who's letting me put it all together. So yeah, it's kind of been like pulling all these pieces to figure out maybe the gap. Like, I think there's this huge gap in our system, and I'm trying to figure out, how do I fill it?
Yeah.
Yeah. If that makes any sense.
It does. And there's so many layers I want to get into there.
Yeah. There's a lot of layers in whatever I just said.
So there was that singular event that page turned.
There was a singular event when my grandma was dying, and it was actually very singular. Like, she took her last breath, and I felt something in the air.
Mm-hmm.
Like, I felt the moment.
Right.
It was the biggest energy that I've ever felt in my life.
And were you close with her? So was
very close.
So there was a bond.
Very close with my grandma on my mom's side. I mean, she was there. The grandma on my dad's side, she died when I was only 1 year old.
Right.
So she was sort of this force that I had always heard about and I always known about. I mean, she was a woman in the medical field when there were no women in the medical
I'm glad you said that, because that's
field.
one of the layers I wanted to get into.
And I wanted to know her so badly, so desperately. And I didn't. But I always had this curiosity about her. And I always thought, well, how do I connect with her? And I think it's now at 48 that I'm kind of sort of now connecting with her in an odd way. Yeah.
But and I'm glad you raised that, because I was going to bring up the point that Aunt Sally for me, your grandmother, was a pioneer, one of the first women in medicine. She was the only woman in her medical school graduating class.
Yes.
And this is 1933, if I remember. I think it was 1933.
Okay.
She graduated from Chicago Medical School. She became an OBGYN, so she went into a subsurgical field. And So I remember her faintly. I went to the funeral, so I probably saw you there.
Okay, yeah.
At your house. I remember there was a sloping front yard at that time,
Okay.
and my grandmother, so Sally's sister, told me years later.
And this is Margaret.
Aunt Margaret,
Aunt Margaret.
for you.
Okay.
And so she told me years later that Aunt Sally said that there were two kinds of men that go into OB. Those that love their mothers and those that hate women. And that always stuck with me. And so he was a woman entering a field when no women were in the field, obviously working with women from a woman's perspective and mindset and physiology and biology and all of that. And her conclusion was that there's two kinds of men in the OB field. So I always thought that was fascinating. But then now she was a pioneer, and you're saying you're connecting with her, and you're a pioneer in your field.
Yeah.
Which,
Wow. I didn't think about it
yeah,
that
that's right. So there are
way.
many layers coming
Yeah.
into this. So you're doing, you're pioneering into a field that's not so man-woman as it is kind of institutional versus human need.
Yeah. I mean, you say that, and I immediately have this flash of the black and white picture, and it's all men. And I
sans.
see, I've seen this photo.
Yes, you know what,
and
I've seen it
there's
too.
Sally, my Mama T. We called her Mama T. It was Mama T and Papa T. And it's her there in the middle in the front.
Right.
Yeah.
And I think that they're all wearing darker clothes, and I think she has a lighter.
Is she? Okay.
Yeah,
okay.
if
like
I
a white-
remember
okay,
correctly. It's been
okay.
a long time since I've seen that composite.
Yeah. We'll have to break that out again
Yeah,
and look
yeah.
at it.
So that was, so I always had, and then of course your grandfather, Uncle Tom, was a surgeon, and so I don't know if they met in medical school, but anyways.
Yeah, I was asking my dad about the story of how they met, and I'm my dad. I'm trying to gather all of the information and get the history now. I think we do this as we get older. We want to know, how did this all form? How, because it's our story too. It's how we come about.
Right.
And yeah, I think they met maybe in medical school, after medical school. Maybe.
Yeah. I don't know.
Yeah.
I don't know the full story.
Yeah.
But I know that Uncle Tom, because I would see him a lot at my grandparents' house. I always asked my grandmother. I'm a little boy, and I'd say to my grandmother, like, why doesn't he remarry? And my grandmother would say, because he loved Sally too much that he could never remarry.
Yeah.
Yeah. And that was that's what I always remember. That's why, because Sally died young.
Yeah. She was
died.
62.
Yeah. She died young.
Yeah.
So the end of life doula care combined with social work, combined with psychedelic integration, family grief counseling, and that's there isn't an encompassing program
No.
to cover those different areas. And so I think in the United States, and I'm going to make that contrast, so I'm bookmarking that. In the United States, there's, we have geriatric physicians.
Yes.
We have hospice.
Yes.
And there's really nothing in between unless you end up at the ICU at end of life care.
Right.
And that's pretty much the three legs of the stool in the end of life care in the United States.
Right. And I think maybe that there could be the argument, chaplains, the chaplaincy, because I think
100%.
there's the spiritual element that sort of like underline a lot of this.
Yes.
And there's also this element of suffering and hope that are sort of a lot of the themes underlying what I am doing.
Suffering and hope.
Hope.
What family suffering, patient suffering,
Yeah.
and hope. Define hope in that context.
Well, I think that it's actually redefining hope, because I think we label hope as getting better. And sometimes hope is redefined in like almost like a resurrection, like in a new spring,
So
in a new way. Like I suffer from a chronic condition, and I have had to redefine what my life is, what living is, because I can't go back to what it used to be before the condition started.
Right.
And that is suffering, but yet I have to keep living. And so what do you do to keep living? Well, one, you got to keep going. You don't give up. Well, I mean, sure, yeah, that's an option, but I have 3 kids, I have a life, I can walk, I can function, but I still have to carry this burden. And so I'm in this process of redefining hope, and I'm still figuring that out. So I guess that's kind of an answer to your question.
Yeah, no, it made sense when you explained it, because I will speak of, I don't use the word hope in peds, but there's a death of former self in pediatrics.
Yes, this is, yeah.
As a parent.
Yeah.
And so I will say, well, my mentor, Dr. Benjamin, who was the quintessential, pediatrician. Everybody loved Dr. Benjamin.
Okay.
And he would say, you're not a parent until you have 2 kids. And I didn't have any kids at the time. And I'm like, that doesn't make any sense. You have a child, you're a parent by definition. What do you mean? But I wasn't a parent, so I didn't know what he meant. And what he meant was, you're not a parent until you have to manage resources. Yeah. It's easy to be you and have 1 child because you're not going to be stretched, again, for most people, are not going to be stretched too far, because you can still identify with who you were previously for your whole life. And then when you have 1 child, spouse, I'm going to go away with the weekend and I'm going to go play golf with the guys. Oh, I'm happy to take the 1 child. Yeah. Or husband, I'm going to go away with the girls and we're going to go shopping in Miami. I'm happy to take my little boy and we're going to hang out for the weekend. But once you have 2 kids, you can't turn to your spouse, especially if they're little, and say, hey, I'm taking off for the weekend. And you're like, what? Because I have, that's a lot of work for me to do. And so there is a page turn where once you have 2, you have to give up who you were previously. So there's that death of self. And you have to redefine yourself in this new way going forward, which is, I am now committed into this life of 2 kids, which it's not reasonable. I wouldn't want to take 2 kids frequently on my own, and I'm not going to expect my spouse to take 2 kids frequently on their own. So we're going to get into this together. And so I have to see myself in a new way as, Brian dad, instead of Brian who he's been for 36 years when he had 1 kid only. And so in my opinion, in my observations over 26 years, parents stop either at 1, 2, or 3 kids, and it's usually the 2 or 3 kids, not so much the 1, that they flip out, that they can't page turn. It's too difficult to have death of self. And so they stop at 2 kids and they stop at 3 kids. And when we had our first, super happy, loved it, super joyful. 2nd kid, I nutted up. Didn't even know it at the time. I was full on overwhelmed. And so that's when most people stop having kids, because they get this sense of overwhelming.
Well, right as you're saying it, I'm having kind of these I have 3, but I'm having sort of these memories of like the autonomic like the nervous system is sort of like
fight or flight.
Yeah. Like you get kind of this overwhelm, and that ability to like calm that system, you have to hone in on it and you have to like practice it. And it's sort of in this kind of environment we all live in, it's so hard to do. Like it's hard to practice, like, oh wait, I need to like calm this system. But you can, you know, like you can do that.
And I think it was acceptance.
Yeah.
And that's what I kept thinking of when you were describing for the family and the grief, and the elderly parent is passing on. So their hope is, the transition out of this realm into the next realm. And then the family has to hope is that, well, they're going to pass and that's going to be better for them. And then I have to redefine myself without mom or dad around, which is, you don't realize until your parents are gone that the story is not written, isn't finished being written until they're gone.
Yeah.
And all of a sudden you start understanding them in a way that you never understood them before. But there's that hope, which is what I was seeing as acceptance of the situation, because there has to be acceptance before you can get into the hope.
Oh yeah, and that word acceptance. Like I think
Much deeper than most people think.
Oh my gosh, and like you look at it like okay, acceptance. Like okay, sure. But wait, acceptance is really hard and it's a process and it's work.
And it's on the days that you don't want to accept.
Don't want to accept it.
And that's when you're really learning acceptance.
Yeah. Yeah.
And that would go with chronic pain condition, or I have got, in my case, I had 5 kids in diapers, and I was single daddying for a while, and I had to sit in it, and when your parents pass and they're getting sick, and you're all that's just,
or you're like kind of in the in between, like the aging parents and the young kids, and like everybody needs you, but what about you?
Right.
Mm-hmm.
Yes.
Mm-hmm. Mm-hmm.
And that's a tough place. Yeah. Very tough place.
Yeah.
So how would you then counsel, looking at that? Oh, there's one other thing I wanted to say just to make sure we weave it into the conversation, because I said I want to place mark the U.S. system.
Oh, yes. Talk about this.
The ministerial, the hospice, the grief social work, and then the ICU as needed, the hospital system as needed. So I'm half Colombian.
Yes.
And so my mom is from Colombia. My parents met in Colombia. My dad's U.S. And my mom returned to Colombia to pass. Okay. She wanted to die at home. Mm-hmm. And so in Colombia, they have a physician that is a death physician, not a Kevorkian style.
All right.
It's not we're going to accelerate the passage. Yep. It is just a death doctor where they just come and visit, and they talk and listen and write. When my mom was actually dying, so you'd pop in every day and just make sure that she was comfortable, and that way she could be at home in her bed. It's easier for everybody. So we made home visits, and when she was actually passing, he was at the house, and my mom was in agonal breathing, which is kind of the end stage breathing. And he said to me, and I don't remember if it was left or to the right, and you might know this. He said, if you turn the head to the left or the right, the soul can more easily leave the body. And I don't remember which way he had me turn the body. Turn the head.
I could be wrong. For some reason I'm thinking it's left, but I could be totally wrong. Mm-hmm.
But I did it.
Okay.
And it's the same thing. I felt as soon as I turned the head, and I wish I remembered. I could, and you think I would have that memory burned into my mind, but I turned the head and I just went, and I just felt her leave. It was right at the moment I turned the head, she went. Yeah. And then, it was very, and I was like, why don't we have you guys in Florida, or in the United States? Why don't we have you guys here? Yeah. And it's just not something that our culture wants to accept.
No.
That's why we spend so much money on end-of-life care, because we're afraid. We haven't accepted.
I think that the discussions, like I used to run something called the death cafes. Have you ever heard of these?
Duck cafe?
Death
cafes. No.
So I ran the Oak Park Death Cafe. And this is where you would come, not because you were necessarily facing death, but so that you could just have a conversation about death. So that this would be something that we were not so afraid of, so that it was not so taboo. Mm-hmm. So that we didn't have to have these because nobody talks about it. Nobody, it's something that's here in the U.S.
Right. It's not in Colombia.
It's not no. And I don't know why that is. I don't know why we don't have a doctor, a death doctor, not a Dr. Kevorkian doctor, like a death doctor who comes and talks to you.
Yes.
It makes you feel comfortable and teaches you how to turn your head. Or we were taking care of a Buddhist client in Boulder, and they said, just open the windows. And so we opened all the windows. And they left.
Really?
Mm-hmm.
No.
Mm-hmm. There's a lot of stories out there.
Yeah. There is a passage
Mm-hmm.
that can be mapped
Yes.
that I don't have an understanding on,
Yeah.
but having these experiences
Yeah.
with people who work in that end of
Yeah.
life area, you can see that they have a
Yeah.
knowledge. It's the same thing it's makes me think of two different things. One is your grandparents knew how to can and how to just take care of themselves
Right.
in a world without a dependency on a larger corporate regulatory dependency relationship.
Yeah. And I actually think, the calmer the body can be. So using things that can calm the body, then the body will know what to do.
Right.
The body will know how to leave. And so, yeah, it's such an incredibly tragic, brutal, beautiful moment. I cannot explain it. I think if you've been in that moment where that you felt with your mom, that moment, oh, it's awful.
Yeah.
It's awful. It's so awful.
But it's a
But
closing.
it's so, you feel it.
Yeah, you feel it, but then
There's-
it also gets closure.
Correct.
So it was like,
Yes.
I was there. I'm glad I was there. I was there.
Yes.
Oh, well, there when my dad died, when my grandfather died. So it's
Yeah. Like I'm struggling to use the words because I don't have the words.
right.
And I think maybe that's why I've gone into the work, because I don't have the words.
The little
Well,
section.
the last thing I'll say on it is that also kind of the, birth doulas and the end of life doula kind of movement came out of the birth doula movement in terms of like, sort of this, I was saying this last night, sort of we come into the world with nothing, we leave the world with nothing. And, the ritual of like washing the body is very similar. And so oftentimes the family will wash the body when an individual dies. Now, some families don't want to do that, and that's fine. It's all individual choices, but that's sort of like a lovely ritual that we would participate in for, individuals, patients, clients, is just like a cleansing of the body and a preparation of the body at the end of life.
This is before or after
Well,
they passed?
after they pass.
After they
They pass, if the individual gave permission. So that, sometimes when someone kind of is involved in their end of life preparation, and they kind of describe to the person, whether it be the end of life doula, the hospice agency, this is how I would like the end to be. They will say, yes, please prepare my body. These are the oils. This is, the gown. This is what I'd like to be in. This is how I'd like my body prepared. Then after they pass, we would wash the body and prepare it. And there's something sacred. So like the sacredness of this final transition on this earth. I really honor that. Yeah.
Yeah. Well, as you say that, one I'm thinking of, one embalming. A next level up would be how the Egyptians prepared people after they died for the journey into the afterlife.
Yes.
As opposed to this person has no value anymore since they're dead. And so there's nothing animating them. There's no significance to them anymore. And we're just going to treat them like cut meat and we're just going to throw it down, But there's not that. There is, and then it just serves as a closure, which is for the family.
Yeah.
And it's a reverence for what was.
And an honoring of however short or long the life was.
Right.
Yes. Yeah.
And now, is it symbolic washing?
However the person was or wanted it. We're all different. We all live a different life on this earth. And so however that person wanted it to be.
Okay.
Yeah.
And I guess, that all depends on a lot of different things and how
exactly.
right. So
Yeah.
anywhere from just symbolic, just wash my face and my arms and my feet to
or other people want like a very specific oil or
right.
Yeah.
Right. Okay. So how does the psychedelic, well, let me, before I get into
Yeah.
that, the end of life dual, it is a recognized pathway? Like you just took different recognized pathways and merged it into your own
Yeah.
collective.
So I was lucky enough to find a hospice that really integrated the social worker as a part of the team, as a part of the team in terms of someone who would help to wash the bodies and to be a part of these rituals. A lot of the hospices, I would say, have been bought up by these larger corporate medical organizations. The hospice that I was a part of in Boulder, there were, 3 nurses and a chaplain, and they left that corporate model and they said, we are going to do the way hospice was intended to be. So they started their own hospice, and it was owned again by 3 nurses and a chaplain, and they are still thriving today. And so I could incorporate kind of all these different, this kind of eclectic mix of things that I do.
What tradition did they pull from? So when you say, so they could do a hospice the way it was supposed to be, what tradition is that pulled from?
So it was a Medicare. I mean, it was funded by Medicare, and it was a medical model. And they, would meet each client where they were at, and I think that's key. Yeah. Meeting the client where they were at. So
that's when you say hospice,
like it was
the way
the hospice,
it should be.
But in terms of the way it should be is they really were focused on not being like this, kind of like how you operate,
right?
Like taking take insurance, but meeting the patients where they're at.
Yes.
And not sort of this, bring them in and send them out,
moving them out,
like sort of like this holistic care. Right. Holistic care is really the best way to put it.
So if it's for-profit corporations, obviously bottom line matters, and then everything
and it's this huge conglomerate.
And
this corporate office way off in
disconnected,
no man's land.
A lot of middle management that aren't connected to
very small, local in Boulder, serving the Boulder County community.
Right.
Yeah.
Right.
Yeah.
And
beautiful.
So when we have, when you go to a corporation type setting that's doing human management care, end of life, pediatrics, whatever, they're going to be interested in the long-term stability of the corporation as instead of addressing what the needs are of the individual in front of them. Yeah.
And then I, as an employee, benefited because I was also then enriched working with them. Right. And so, I would assume that's how it is here. Your employees also are enriched, because it's just a smaller model.
Right.
So that was the work that I did there. Then I got sick. And so kind of had to rebuild things, but then I moved over to, my therapy work and, have kind of restructured things. And that's been some of the psychedelic work, but the psychedelic work, there were clients who were also doing psychedelic therapy at end of life in the hospice. But now within the therapy model, there is psychedelic assisted therapy that is legal in Colorado, for mental health therapy. And it's pretty incredible. I mean, it's phenomenal, for mental health therapy I have clients that have been through so many different therapeutic models for depression, anxiety for years. And after 6-7 sessions, they're out. Depression is better. Anxiety is better. So that's been extremely incredible. And I do the psychedelic integration from, like one-on-one therapy after their treatments.
Right.
Yeah.
So the psychedelic part of your care, that's been an
Yeah.
evolution, because we know in the 60s psychedelics were used and advocated by Timothy Leary at Harvard, and that has a whole storyline in itself, but that research was basically shut down.
Yeah.
The government, academic institutions, everybody was scared about what would happen if psychedelics were unleashed on society. And there was some misinformation, and there was some politics involved, and it was part of a cultural change. So it was put away. Psychedelics were locked away. Schedule 1 drug, no beneficial human use at all until 1999. And Dr. Roland Griffiths, who was at Johns Hopkins School of Medicine, he was a very distinguished researcher. He resurfaced the use of psychedelics for psychiatric care.
Yeah.
And he was so well decorated that the FDA, the IRB, which decides whether a research project should happen, they approved it because he was such a solid, objective researcher that it was probably only he could have resurfaced this, because he was just the right guy, right time. So he worked initially with terminal patients who were fearful of their impending death, had anxiety over their impending death, and he dosed them with psilocybin, which is the mushroom, magic mushroom, and the results were overwhelmingly positive. 90%-ish of all the research subjects after a session or two of psilocybin, high dose psilocybin, not recreational or microdosing,
Yeah.
but high dose, guided with somebody that they had already established a relationship. Very structured. It was an academic setting. It was all done in the hospital. They were no longer fearful of their death.
Incredible.
They completely accepted their death, going back to that term of acceptance. They had an inherent, grounded, foundational acceptance of their impending death, to the point that they then were counseling their family members about how everything was going to be okay, and there was a plan to everything. Even those individuals, because they also looked at it from a religious standpoint, those who were atheists versus those who had a spiritual practice. And even the atheists were still, they wouldn't recognize fully that there was a divine plan, but they had a peace that everything was going to be okay. And so it transcended everything. Then he went on to research into substance abuse, which is a whole nother topic. And just as a quick aside, one single use of high-dose psilocybin results in a 5-year smoking cessation.
Yeah.
It's insane.
It's incredible for substance abuse as well. It really it changes the neural pathways.
Yeah, it rewrites it rewrites the programming.
Yeah.
That can be rewritten.
Yeah.
And so tell me how one in the grief and end of life care, do you notice a difference between those who have a spiritual practice and those who don't, or are atheists?
Oh yeah.
There's a different path.
There's
Is it so distinguishable that right from once it's like an intake question, and then you walk them down different paths because
yes,
you know that?
yeah, it's in the initial assessment. It is, well, one, it determines the team. It's who we bring in as the team for who's going to be the support system. And then it also kind of makes the difference for how the conversations go, how the support goes. And you said how you had mentioned in the study how the individual supports the family. It's actually sort of the spiritual piece is so fascinating, because peace, there does seems to be a different level of peace. And I think that part and a questioning, of course. But it does determine, who comes in as the support network.
Yeah, that makes sense.
Yeah.
So it really defines, because there's certain parts of my practice in pediatrics that once I find out what the value set of the family is, I will walk them down different paths. I will mention the other side so both sides are
Yeah.
aware.
Yeah.
But there's definitely a bifurcation that because the foundation of how they perceive the world is structurally
Yeah.
and completely different.
Yeah.
How then is psychedelics? I know in Colorado that they're legal to do in therapeutic
Yes.
setting.
Yes.
And here in Florida, I'm aware that ketamine can be used because I know there's ketamine clinics, but I
Clinics,
don't believe that
okay.
there's any type of psilocybin use in the state of Florida. I'm not versed on this. So how is the ketamine and the psychedelics used in Colorado? Because it's a state by state
Yeah.
decision. And I know in Florida there's ketamine. I don't know much about the law. I just know
Okay.
that people will go to ketamine for different mental health reasons.
Yeah.
And in Colorado, I know they're one of the first states that's allowing psilocybin and ketamine. So it's an evolving regulatory political process still, even in Colorado.
Yeah.
So they're pioneering it, but I don't know. Can they can you distribute through the hospice, or people like I know you can order magic mushrooms online
Yeah.
and they can be mailed to your house.
Yeah,
So access to it is not the issue. It's the structuring to have somebody walk you through the journey of a psychedelic that's important.
Yeah.
So how does that all handle?
Yeah. So currently, as licensed professionals, we are not walking individuals through like the psilocybin because there's still the legal and the regulatory process. However, there are others, non-licensed still, walking people through it. With the licensed centers, we are though with research, evidence-based ketamine, psychedelic experiences, really having tremendous amounts of success with ketamine, whether that be IM, which is intramuscular, IV, and that is through a very regulated process. And for example, at our organization, we require 3 to 4 therapeutic sessions, talk sessions with a therapist like myself. So we call that pre-integration, where we are doing intention setting, sort of doing some initial assessment and processing. Then an individual would meet with our nurse practitioners and do the actual ketamine treatments and have the psychedelic experience with the ketamine.
Both patients and family members.
If it's a youth, we actually do youth too.
Oh, okay.
So like about 15 and up. And then we have the post-treatment sessions for as long as we deem needed with the therapist, because there is a lot of, just kind of like decompressing about the experience. There's a lot that comes up in the experience.
There's a lot of integration.
There are a number of, I think, ketamine clinics where you just go in, get the treatment and leave. But I think the pre and post integration about what you go through during these psychedelic experiences, that's where the change happens. That's where the understanding of the change in these neural pathways and kind of the thought processes can really be transformative for individuals' lives. I mean, I have clients that I've worked with who've been just kind of living in depression for so long. They've tried everything under the sun, 6 or 7 sessions, and they're out living their lives. It's really unbelievable. And then what's happening with the regulatory for psilocybin is now starting to happen in terms of then licensed centers like ours, where they can come in. We have already set up like a wellness center so that they can have the experience at our location. And this is just kind of now getting off the ground.
Right. And since it's a burgeoning young field,
right,
and ketamine has had a longer runway to get off the ground and have protocols put in place and evidence-based research to support the protocols, whereas that has not necessarily happened with psilocybin.
Yeah.
And recall when I was speaking about Roland Griffith, that this was all done in a very hospital clinical setting, but there hasn't been a lot of outpatient work, which is kind of the data that's being gathered now in order to put protocols in place. So it just doesn't turn into a psilocybin distribution center for whoever just wants to roll by.
Right.
And I want to emphasize one point, and then we'll start wrapping up, is when you say that the pre and post therapeutic sessions before the integration session is very important, because being taken and losing self, ego, identity through psilocybin or through a ketamine, you need to have a debriefing.
Yeah.
You need to understand what's happening and what's to do afterwards. Otherwise, it's just a drug experience.
Right. And to be, as a licensed clinician, like, I'm also screening these individuals to determine, well, this isn't just a person coming in for a recreational experience. Like, this is a treatment too. And so, and, a lot of individuals coming in for trauma, the traumatic experiences, and kind of having like a support system around you, pre and post, is very therapeutic, having someone walk alongside.
Yes.
Yeah.
And the best, there's a couple different modalities that people are using. So one is ketamine.
Yeah.
Psilocybin. Some people are finding ayahuasca.
Yeah. MDMA is another.
MDMA.
Yep.
Yes. And then ibogaine.
Yes.
Would be, and I'm not going to get into all of those different ones, but there's different reasons to pick each of those different substances. Those who are returning from war, veterans, are really focusing on the ibogaine. And then, but I'm just going to leave that at that description. But the best, the best conceptual framework that I've heard about doing ayahuasca, and I would assume high dose psilocybin would be similar but somewhat different, was that when you're born on top of a mountain that you ski down every day. And I heard this from Michael Pollan. He was given a description in one of his lectures, and he was given this description. So I'm borrowing it from Michael, who bought it from somebody else. And that is, every morning we're born on top of a ski mountain, and our parents, when we're little, teach us how to ski down the mountain. So we pick up these family habits, and then that's just how we ski down. And then when we wake up the next morning, we have to ski down the mountain. After a while, we've rutted a path. This is what we know because that's what our family taught us, and we just keep engaging in the same activities, which often are hurtful or not beneficial or anxiety-provoking. But then when you do the high-dose psilocybin or you do ayahuasca, and again, the pre and post integration is very important, is when you wake up after doing those medicines, there's been a fresh snowfall on top of the mountain, and you don't see the rutted pathway down, and you don't see, or you don't have the belief that I have to go down this way anymore, because there's actually no path there anymore. It's you're standing on top of the mountain looking at every possibility, but now you have integrated what's happened to you in your past. You've accepted it because of this experience, this psychedelic experience. Whether you're atheist or a spiritual believer, it's the same for both groups. And then you pick how to go down that. And that's why you're seeing 90% smoking cessation. That's why you're seeing terminal patients who no longer have anxiety and now flip and become the therapists themselves. It's amazing.
It really is incredible, and I'm glad to see that there's just like a wider net, and a more open. And I'm curious. I'm curious to see where this can go. And you had mentioned with substances and addiction, and that's another well-worn pathway that can be sort of like released.
Right. And then there's a lot of political support for this. So Governor Rick Perry from Texas, he's former governor of Texas.
Yes, I've heard in terms of like the substance abuse support.
For substance abuse and PTSD. PTSD. So he is a very, very conservative governor. And he never done drugs. And he has seen the benefits in veterans from ibogaine use. So he is a huge proponent, active proponent of opening these modalities here in the United States to help our veterans and recover from the PTSD from the events they experience.
Yeah, that's a really important, because the trauma informed approach with these medicines, in terms of the pre and post therapy, I think will really be a good blend.
Yeah. Well, good. Well, thanks a lot for joining me today. This was totally
Yes.
impromptu and it was great. And
Yeah, we were all over the place. So much good stuff. I could go on forever.
thank you for joining us on the Dr. Thornburg Wellness Podcast. Come for the science and common sense. Stay because it works.